Everybody, welcome to this national webinar at Believers Church Medical College and Hospital. This is our 76th webinar. Due to various COVID constraints, we had to stop our webinar sessions for a while. It's been almost 2 months since we had our last webinar, but then we are back. And how? With this amazing session on anthropometric charts, a very important topic straddling both pediatrics and endocrinology. And we have a very special speaker for you who will be introduced shortly. And to give an overview of the session, we have one of our moderators, Dr. Sujin Mariam Thomas, who is our assistant professor of pediatrics. She's completed her undergraduate from Tanjavur Medical College in Tamil Nadu, and she went on to complete her post-graduation in pediatrics from the prestigious Pondicherry Institute of Medical Sciences in Pondicherry. And she's joined us as a compassionate, caring, and extremely competent a pediatrician, and she's been a great asset to our department and the institution at large. So, and we have another moderator, our senior endocrinologist and professor of general medicine, Dr. Anuleka Mary John. She's doyen in the making, an extremely competent and again very compassionate endocrinologist and physician. So she will be introducing the speaker for us. Before we go into that, let me hand over to Dr. Sujin to give an overview of the topic and hand over to Dr. Anuleka. Over to you, Dr. Sujin.
Good evening, everyone, and thank you, sir. Thank you for those kind words. Okay, as sir said, today we'll be talking about growth and anthropometry, especially growth charts. And as we all know, growth is an essential feature that distinguishes a child from an adult. And also, evaluation of growth is a crucial element in the physical examination of a child. And as we can, from our experience, deviation from normal growth will be the first sign of many diseases. So with this brief introduction, I would like to call Dr. Anuleka to introduce our speaker, Meghna Chawla.
Good evening. Today, I'm really happy to introduce Dr. Meghna. Dr. Meghna Chawla is a well-established pediatric endocrinologist. After having completed her DNB in pediatrics, she went on to do her fellowship from UK, from the Royal Manchester Children's Hospital in pediatric endocrinology. She is working as a consultant of pediatric as well as adolescent endocrinology in Ruby Hall Clinic, Pune. Madam is published, and she's got many articles to her credit, also several awards and applauds. Madam also heads several projects under the ICMR, and we look forward to hearing from you, Dr. Meghna, and over to you.
Thank you, ma'am. So good evening, everyone. Thank you very much for the kind introduction. Thank you, Dr. Jacob, Dr. Anuleka, and Dr. Sujin for inviting me here today to speak on a very essential topic in pediatrics and the basics of endocrinology, that is anthropometry and growth charts. So I hope by the end of this session, most of you are at least aware of what kind of anthropometric measurements are required to understand pediatrics and the basics of pediatrics, as well as understand what growth charts and how to briefly interpret the basics of growth charts is what our endeavor would be in this session. If I would request ma'am to please share the screen so that we could proceed.
Yeah, we'll be just sharing your screen, ma'am.
Full screen share ചെയ്താൽ മതി. ഞാൻ അവിടെ നിന്ന് ആക്സസ് ചെയ്തുതരാം.
Is the screen visible, ma'am?
Yes, madam.
Okay.
Thank you very much.
Okay.
So, as Dr. Sujan has already explained, anthropometry is the basics of pediatrics and, of course, the basic of pediatric endocrinology. And as most of you, as I understand, Dr. Jacob told me, are undergraduates in this medical college. This is very important for you all to understand because this will help you not only in your undergraduation, but if you do some post graduation in pediatrics, then this forms the basis as well. So let's start right from the beginning. Anthropometry is nothing but a measurement of growth. And growth depends upon various parameters, the most important of which is weight and height. So let's see how we take weight. You all know there's a digital weighing scale, okay, and there'll be a baby infant weighing scale for an infant, and there will be a standing digital weighing scale for people who can stand, for kids who are more than 1 year of age. Now let's see how weight goes. It usually doubles the birth weight by 4 months and triples by 1 year. Simple formula to calculate an average weight for a child who's between 1 to 6 years of age is 2x plus 8, where x is the age in years, and between 7 to 12 years, 7x minus 5 by 2. If all of you can please note down these formulae, I would be happy to share this presentation as well. You would at least have a brief idea whether the weight of a child who comes to you is normal or not. Now let's take an example. Suppose the birth weight of a child is 3 kg. The kid should be at least 6 kg by 5 months of age, and we can triple it, that is around 9 kg by 1 year of age. After 1 year of age, okay, you can use this simple formula to understand if the kid is say 1 year, then 2 into 1 plus 8 is 10 kg. If 2 years, 2 into 2, that is 4 plus 8 is 12 kg. And that's how this formula goes on. Next slide, please. So the other important parameter to measure is height. And measuring height is not as easy as measuring weight because you have to have some proper parameters in place. Now, as you can see on the left side, okay, in children less than 2 years of age, an infantometer is used because supine length is measured. And whenever you use an infantometer, as you can see, 2 people are required. One who holds the head and the head end of the infantometer, and the other who is adjusting the flexible end of the infantometer to the sole of the feet. And by this way, you can accurately measure the length of a child less than 2 years of age. The same length becomes height for more than 2 years of age, where you can see this is an example of height being taken by a stadiometer. And as you can see, the end of the stadiometer is carefully lowered down till the head. Okay, and please note where she has kept her hands. Her hands are kept on the mastoid process. That's exactly how you're supposed to take height, because some firm pressure on the mastoid process straightens the spine. So height is measured to the nearest millimeter. So to sum it up, in children less than 2 years of age, supine length is taken by an infantometer, and in children who are more than 2 years of age, standing height is measured by a standing height stadiometer. Now, if you can see, there is something called body proportions. Okay, why we want to know about body proportions is because we want to know if the child is growing proportionately or disproportionately. As you can see over here, where there are very few centers in India which will have this kind of apparatus called a sitting height stadiometer. Okay. Now, sitting height stadiometer is how this child is sitting over there. And as you can see again, the doctor has his hands placed on the mastoid process, and there is firm pressure applied over there. And that is how you take the upper segment height and a lower segment height. And this is how it changes from birth to maturity. The clinical implications of this I will soon discuss with you. In places where you do not have a sitting height stadiometer, the best way to measure the upper segment lower segment ratio is to take a measuring tape and measure it from the tip of the pubic symphysis to the toes. That will be your lower segment, and if you subtract that from the total height, you will get the upper segment. Please remember these basic parameters of growth. In newborn, the upper segment to lower segment ratio is 1.7:1. That means the trunk is larger than the limbs. By 7 to 10 years of age, it becomes 1:1, that is, it equals. And in us, it is 0.9:1. So that reaches by adolescence around 13 years of age. Now, there are some conditions where the upper segment, lower segment ratio can be skewed. Why it is important to know is that there are certain conditions where you get disproportionate growth. Suppose the upper segment is more than the lower segment, that means the limbs are short. And limbs are short in certain conditions like achondroplasia. If you have ever visited a circus when you were small and you saw the dwarfs over there, the most common skeletal dysplasia is achondroplasia. And in those, they have very short limbs. I'll be shortly showing you a photograph of that. Then rickets. If there's rickets, you know there is bowing of the legs, etc., which causes the limbs to shorten. Hypothyroidism is another example where upper segment is more than lower segment. And if upper segment is less than the lower segment, that means there's a problem in the trunk. So that could happen in something like some spinal disorders like spondyloepiphyseal dysplasia, kyphoscoliosis in which the spine is bent, and mucopolysaccharidosis such as Morquio's type 4. So this is what I'm trying to explain to you. As you can see, there's short trunk versus short limb. The lady, okay, as you can see, has a short trunk, whereas the gentleman who she's hugging has short limbs. So this is how you can actually make out disproportionate growth. And that is where upper segment, lower segment ratio is so important to know whether the child is growing proportionately or not. And this is a wonderful picture to show you all kinds of dwarfs and all kinds of short stature. One of my favorite pictures, as you can see the row in front, there are some with short trunks, there are some with short limbs. So this is how disorders of skeletal growth actually look like. And this is called disproportionate short stature. So simple guidelines about growth velocity. See, when a child comes to you, you take the weight, you take the height, and you plot it. So that is a one-time cross-sectional kind of view of growth. But to actually know whether the growth is specific or not, we need to have some guidelines about growth velocity. Growth velocity is nothing but how many centimeters is a child growing in 1 year. So as you know, the infantile phase, that is the first year of life, is a rapid phase of growth. So if the child was 50 centimeters at birth, remember they grow 25 centimeters in the first year. That means if they was 50 centimeters, the child will be 75 centimeters by 1 year. You can half that, around 12 centimeters per year in the second year. And after the age of 4, at around the age of 4 years, it is usually 100 centimeters, after which they grow around 6 to 6.5 centimeters per year till the onset of puberty. Now, puberty is another phase of active growth because you have the sex steroids, estrogen and testosterone being secreted at the time of puberty, and that kind of synergizes the effect of growth hormone to produce something called the pubertal growth spurt. Now, in boys, it is as much as 20 to 30 centimeters, that is, and in girls, it is 15 to 20 centimeters. This is an average height gain of an Indian girl and Indian boy during puberty. It is important to know that what is the pubertal growth spurt and what should be the normal pubertal growth spurt, because there are many disorders in endocrinology such as delayed puberty or precocious puberty in which this pubertal growth spurt carries lots of value. So a normal growth velocity has to be known. This is the basic. Only then you will know what is abnormal. So when do you refer to a pediatric endocrinologist? Any child between 5 years till the onset of puberty growing less than 5 centimeters per year should be evaluated for short stature. Now, let me stress on the fact that any kind of, duration between two anthropometric measurements should be at least 3 months apart. So if you take the height at a particular year, you have to continue taking the height every 3 months. And if the cumulative height of 4 measurements is less than 5 centimeters per year, you should be evaluating the child for short stature. Now let's go on to the next important anthropometric measurement called head circumference. If you can see this tape, you need to use a non-stretchable tape to take the head circumference. It's quite obvious. So I'm sure most of you know, and in your clinics, ma'am has already taught you, the landmarks are posteriorly the external occipital protuberance and anteriorly just above the glabella. So let's take a look how head circumference grows and what is the normal way that head circumference should grow. Next slide, please. So for the first 3 months, it grows 2 centimeters per month. For the next 3 months of life, you can half that if they grow 1 centimeter per month. And for the next 6 months, you can half that 1 centimeter to 0.5 centimeters per month for the next 6 months. It's important to note that if you're taking the head circumference in a neonate, it is inaccurate till day 3 of life because of the molding, etc. Hence, it should not be measured before 24 hours of age. Okay, so if you're taking the anthropometric measurement of a neonate, please take head circumference only after 24 hours. So if you know the normal head circumference, you will know if the head circumference, if the child has microcephaly or is heading for some kind of hydrocephalus or macrocephaly. So it is important to know what is the normal head circumference and how it grows. A simple formula for head circumference up to 1 year of age is this. This is Dine's formula, and all of you can please note it. If you can share my presentation with the students, it would be great. They could note it as well. Next, please. The fourth important anthropometric measurement is chest circumference. So chest circumference has to be taken with a measuring tape at the level of the nipples. In the term baby, head circumference is 2 centimeters more than the chest circumference. They equal the head circumference by 9 to 12 months of age, after which the chest circumference is more than the head circumference. This is what you need to know, that it is only after the age of 1 year that the chest circumference is more than the head circumference. Now, not all babies grow at this rate that I have mentioned. So suppose a baby is born preterm, say less than 36 weeks of gestation, or SGA, that is less than 2.5 kg. You give them a time to catch up, okay, so that they can grow as a baby who was born more than 2.5 kg birth weight. So there is a time period by which we have to wait, and that time period is 18 months for head circumference, 2 years for weight, and 4 years for height. If a preterm child does not reach the height of a term child by the age of 4 years, that is another indication for referral to a pediatric endocrinologist so that we can look into the matter and make them catch up like a term baby. The other important anthropometric measurement is mid-arm circumference, and the landmarks for the mid-arm circumference are between the acromion on the shoulder and the olecranon process on the elbow, and a special tape known as Shakir's tape is used to measure the mid-arm circumference. And another, which is not so common but an important anthropometric measurement, maybe from the theoretical point of view or from the research point of view, is skin fold thickness. It is used using Harpendon's calipers, and it is measured over the triceps. Anything that is normal is more than 11 millimeters on the calipers. So these are the measurements. Now, some important formulae for calculating mid-parental or target height. This is also important because shortly I'll be showing you some growth charts, and I'll be showing you the genetic potential and how to calculate the genetic potential for growth. So for boys, you have to take the average height of the father and the mother and add 6.5 centimeters for boys, and take the average of the father's height and mother's height and subtract 6.5 centimeters for girls. You get something known as a mid-parental height at the age of 18 years. And target height is anything 6 centimeters above and below the mid-parental height. So that gives us a target range for which the genetic potential of height must fall upon. Now, one of the last anthropometric measurements, but very important one, is arm span. So arm span has to be measured with the arms held at 90 degrees to the floor, and it has to be compared with height. Now, in toddlers, arm span is 2 centimeters less than the height. By 7 to 10 years, it equals the height, and after that, it is 2 centimeters more than the height. Why is it so important to know? Because there are certain conditions where you have arm span which is more than the height, and the most common of them is Marfan syndrome. And I'm sure most of you have seen Marfan syndrome with some cardiovascular conditions in your clinics. The other conditions that can cause arm span more than height are homocystinuria, and very important, the chromosomal disorder, Klinefelter syndrome. So this is how clinical pointers in anthropometry can actually lead to a clinical diagnosis as well. So after anthropometry, the basics of anthropometry, you need to plot it on growth charts to understand whether you're dealing with a normal measurement or are you dealing with an abnormal measurement. So growth charts are the basics of pediatric clinical examination. Let's take a look at some important pointers on growth charts. So see this interesting figure. The first growth curve was plotted 200 years back by Count de Mountbeillard, and this is the first ever growth chart in history. 200 years back, he actually plotted his own son's height every 6 months from birth to 18 years, and this was subsequently published 200 years back, and this made history. After this, growth charts have improved and improvised a million ways, and now we have fantastic growth charts to see various anthropometric parameters, but this is how it all started. So there are some important concepts about growth charts before we proceed to them. There are two types of growth charts. Okay, one is a growth reference and one is a growth standard. So what do you mean by growth reference? Growth reference is a statistical summary of anthropometry in a reference group of children. Reference group of children, what I mean is, suppose you take a geographic region at a particular time. Suppose you take a particular state, say the state of Kerala. You measure the anthropometry and height of all the children currently residing in Kerala, and then you statistically summarize them and form some growth charts. Okay, that is called a growth reference. And a very, very kind of important example is the IAP growth charts that were constructed in 2015. They were based on a reference group of children from all zones, and they actually describe the real time situation. That is how the children in a particular geographical area are currently growing. Whereas growth standards are something which are an ideal situation, like the WHO growth charts. Now, WHO constructed growth charts based on very, very particular parameters, okay, like only healthy children were taken, only breastfed children were taken from good socioeconomic strata. They actually form a benchmark that this is how children should grow if all kind of confounding factors are neutralized. So they describe how children ought to grow. Okay. Growth charts are nothing but graphic visual representation of growth references or growth standards for clinical use. So they are, as I told you, a statistical summary of the anthropometry of the reference sample. And they have become an integral part of clinical examination as well as pediatric clinical workup. So this is a little about the WHO growth charts that were constructed in 2006. So a very, very highly controlled study was taken up by the WHO, and these were the countries chosen. And New Delhi, India, that to South Delhi was one of the sites for this multi-center growth reference study, considering the India is the most populated country, one of the most populated countries in the world. So that is how it was good that our country was also one of the study sites. And from all these study sites, okay, 8,500 children's anthropometry was collected and it was analyzed, and that is how they constructed growth standards, which are very well in use from 0 to 5 years of age. Now, let's go on to from 5 to 18 years, what do we use? The Indian Academy of Pediatrics realized in 2015 that the original charts that we had for India were constructed in the 1980s by Dr. Agarwal. Okay, so there was a need for a country-specific growth chart. I'm sure all of you agree that children who are brought up in Europe or in America are much taller than the Asians. So to have one single growth chart or one size fit all was a little difficult. So we needed country specific growth charts to see actually how our children are faring and where do they fall. So there was a secular trend. Okay, children were developing quickly. There was a state of nutrition transition, and of course, how can we ignore the epidemic of childhood obesity that is occurring, and especially post-pandemic? This is one of my commonest referrals that comes in is childhood obesity. So what they did was they collected data from 33,148 children. They kind of reviewed the data from Indian Pediatrics Journal of the last 10 years, took out some anthropometry, and they kind of constructed some growth charts. from all the 5 IAP zones. So for growth chart interpretation, there are certain steps to be followed. Step 1 is accurate anthropometry. The correct steps already explained to you. Step 2 is plotting the correct growth chart. And step 3 is how do you interpret the plotting points. So let's go ahead and see how we can do these things. Important to note that you have to choose the correct growth chart. Okay. So if the child is between 0 to 5 years of age, you need to use WHO growth charts. 5 to 18 years of age, you need to use IAP 2015 growth charts. All are freely downloadable on the internet. Now, assessment of growth may be longitudinal or cross-sectional. What I mean by cross-sectional is a single point. Longitudinal is when you're following up growth over a period of time. So longitudinal assessment of growth entails measuring the same child at regular intervals. And what I mean by regular is every 3 months. Okay? And you need to compare all these measurements to growth standards. Now, why are we so worried about growth assessment? It is important because we need to know whether whatever anthropometry that we have taken, and we need to determine whether the child is growing normally or has some kind of growth problem that needs to be addressed. Okay, so that is the whole purpose of it. Now, whenever we are studying, some books tell us that talk about Z scores, some talk about percentiles or percent of median. Let me tell you, all of them are correct scales of measurement. It depends upon which growth chart you are taking and follow the correct growth chart. So the available WHO growth charts for 0 to 5 years, which are there in all our textbooks and online, are length or height for age, weight for age, weight for length, as well as BMI for age. IAP growth charts between 5 to 18 years of age are available only for 3 things: weight for age, height for age, and BMI for age. So this is how IAP growth charts look. As you can see here, there is an x-axis and a y-axis. On the x-axis, you have the age in years. Okay, and can you see the percentile lines down? The percentile lines below are the percentiles from 3rd to 97th percentile for weight, and 3rd to 97th percentile for height are the percentile lines depicted above. And they are color coded, okay, blue for boys and pink for girls. Next, please. This is another interesting growth chart, which kind of you can plot for upper segment, lower segment ratio to accurately see whether they are growing proportionately or not. These are also downloadable on the internet. Okay. So how do you interpret? What are the problem situations? Suppose a child's growth line crosses a percentile line too quickly or too late, or kind of it's decelerating. Then these are the things where we need to see. We need to see what is the kind of trajectory of growth on a growth chart to actually understand whether the child is growing normally or not. So to kind of make all this a little more clearer to you, I have added a few case scenarios, okay? And I do not know if your curriculum has OSCEs, but these are commonly asked things to interpret. So let's start with the first case scenario. So these are actually real-time patients who have come to me. So Akash is a 6-year-old boy who comes to your clinic with parental concerns of decreased height, and we took all the history and examination for systemic, etc., family history. Everything was inconclusive. However, the parents felt that the child is short. So the height was 110 centimeters, weight was 18 kg, and this is the father's height and mother's height. Okay, since he is Akash, we calculated the mid-parental height for a boy. That is, we took the average and added 6.5 centimeters. And as I told you, target height is anything plus or minus 6.5 centimeters from the mid-parental height. If you could please click, ma'am, there would be some points coming in. So as you can see, the red point is at 110 centimeters, that is height, and it falls on the 25th percentile. That means it's normal. And can you see the weight? The weight is also on the 25th percentile, which is normal. And if we plot the mid-parental height, okay, at 163.5 centimeters at the age of 18 years and 6 centimeters above that and below that. Ma'am, could you please press? Yeah. So that is what you can see as the target height. And if you plot the growth trajectory, the height is falling within the genetic potential. So all you have to do is reassure the parents that Akash is a normal boy and he's growing normally according to his genetic potential. So this is how you kind of interpret growth charts. So let's look at another case scenario. Now Nikita came to us. She's a 10-year-old girl and she had complaints of being short. Okay, these are very common scenario. Many kind of state level skaters and javelin throwers and God knows who all come to us, okay, for height increase. So she's a state level skater and her parents wanted to know if she was growing adequately to qualify for the national team. So we took a height, it was 120 centimeters. This was a weight, and this was a father's height and mother's height. So let's see how the plots stand. Can you see the height is less than the third percentile on the growth chart? Okay, but the weight is on the 10th percentile. So anyone will think that this is short stature, right? Because any child whose height is less than third percentile on a growth chart for that particular age qualifies for short stature. But when you take the mid-parental height, that is, you take the average and subtract 6.5 centimeters from the average because she's a girl, this is where the plot falls. And for the target height, 6 centimeters above that and below that would be the target range. Ma'am, could you please press the pointer? Yeah. And down as well. So if you see the growth trajectory of a height, she's falling within her genetic potential. So this is nothing but a familial short stature. Nikita is short because her parents are short. She has inherited the short genes from her parents. So this is nothing but a familial short stature, which is a normal physiological short stature. There is no pathology because of which she's falling below the third percentile except the genetics. So all you have to do is reassure the parents that she's short because of her family history being short. And she's short because of a familial short stature for which no kind of intervention is required. Okay. So let's go on to the next example on growth charts. So let's take a look at Simran. Now Simran is one of my patients. She's a 10-year-old girl who presented with complaints of lethargy, increased weight gain, dry skin, and excessive sleepiness since 2 years. Now, any one of us would know that these are typical symptoms of something called hypothyroidism, when you have low thyroid hormone levels circulating in your body. But at 10 years of age, her height was only 100 centimeters, which should be a height of a 4-year-old child. And look at the weight, it was 47 kg, which was quite high compared to the height. And this was her father's height and mother's height. So let's take a look at the plots. Look at the weight. The weight is almost on the 97th percentile, but look at the height, it is way below the third percentile. So we started her on levothyroxine replacement therapy, and this is how she progressed. Can you see? And finally, at the end of it, at the end of 2 years, she had reached her genetic potential. So just a small tablet of levothyroxine, if given in the correct dose, if diagnosed correctly on time, okay, because hypothyroidism is an important endocrinal cause of short stature that you need to rule out, you can actually make the child grow normally and they improve magically, okay. So this is how Simran looked before her diagnosis. Ma'am, could you please press that? Okay, can you see how obese she looks, short with dry skin, and she looks sleepy, not alert. And this is the same Simran after 1.5 years and 2 years of treatment. See how alert she looks, how much weight she has lost, okay, and she looks much taller. So this is how magically hypothyroidism improves, okay, if you diagnose it on time, okay. So this was a case of autoimmune thyroid disease, okay, which is under our treatment. So this is how beautifully growth charts can tell us what is normal, what is abnormal, okay, and how to go about particular things. So it is important to keep a growth chart in every pediatric file, okay. Now let's go on to something more interesting. We've had enough of examples of short stature. Now let's take a look at this. A 7-year-old boy came with a diagnosis of Marfan syndrome. Now, I'm sure each one of us know Marfan syndrome kids are tall and arm span is more than height, like I mentioned before. Okay. So he came with a height of 137 centimeters and weight of 20 kg. Can you see the height? It is more than the 97th percentile on the growth chart, whereas the weight is on the 50th centile. And if you compare it with the mid-parental height, okay, He was quite tall for his mid-parental height. One could please check. Yeah. So if you see the trajectory, growth trajectory, he's growing taller than his genetic potential. And if you take a look at the heights of the parents, father's height was also 180 centimeters. He was also very tall. And when we examined him, the father also had Marfan syndrome or Marfanoid happiness because it has an autosomal dominant type of inheritance. Okay, so this is how he looked. Okay, this is how Marfan syndrome is. Can you see that point over there? That points to 97th percentile. Okay, and this is how this boy looks with Marfan syndrome. Now see, this is about normal growth and abnormal growth and a brief basic about which growth chart to use and how to interpret certain endocrinal conditions on growth charts. But you must understand that all these growth charts have been constructed for normal children. Suppose a kid comes to you with a syndrome or a genetic cause of short stature, it is not fair to plot them on normal growth charts. For that, you need syndrome specific growth charts. If you could please change the slide, please. Okay. So the next slide will show us a typical example of, this is a spot diagnosis of Down syndrome. Okay, so this is Lucas Warren and he's paid 1 million US dollars just for being so cute. And this is a typical example of a Down syndrome kid, up and down. And as you know, Down syndrome kids, everything is delayed. Their growth is delayed, their development is delayed. So you have specific Down syndrome specific growth charts. This is how they look like. Okay, they're freely downloadable online on the internet. And this is the correct growth chart on which you should plot a Down syndrome kid if they come to you. Okay, because they do not grow like a normal child. You have to compare Down syndrome kids with other Down syndrome kids to understand whether they are growing normally or not. Another similar example is Turner syndrome. Now see, this is the second most common thing that will come to you. Okay, is Turner. Turner girls are all short. Okay, and you know they have the karyotype XO, most of them well. And this is a US gymnast actually who is a Turner syndrome. And if you had to plot the height of a Turner syndrome, again you need to use Turner specific growth charts. Okay, so like you have Down syndrome specific growth charts, you have Turner specific growth charts, and there are other genetic conditions like Prader-Willi, other skeletal dysplasias which have syndrome specific growth charts. So always remember, growth charts are to be used only for normal children. They are not to be used for syndromic children. For syndromic children, you have syndrome specific growth charts, which you can Google on Google Images and just download it and plot it correctly. Next, please. So this is important for us to know that there's some very important online resources by which we can see growth, of which one is WHO Anthroplus. And for those who are interested in research on growth, you can get in touch with me because we have lots of work going on growth. So it is a free to download software for anthropometry based studies. Okay, there are some nice applications, okay, phone apps on iOS and Play Store called Pediatric Growth Chart and Growth Calc. Okay, Growth Calc also has syndrome specific growth charts. So you can actually go on to these applications, download them. And if the child comes to you, just add their date of birth and the present date and the weight and height, and it automatically plots the growth chart for you. And that can be shared with the parents as well. So these are some useful internet resources which are available free of cost. For all those who want to read further on growth and short stature, these are some of the chapters that are there in postgraduate textbook of pediatrics by Dr. Piyush Gupta sir. Okay, we have authored the chapter on abnormalities of stature where you will get a little more information above this basic knowledge on growth. Also, an important online resource is the European Society for Paediatric Endocrinology e-learning portal for resource-limited countries. Okay, it is available free of cost. You can go in, log in, and you can read the chapter on growth disorders by us as well. So we will be able to throw some more information for further reading on these chapters. So thank you very much for your kind attention, and it was a pleasure interacting and speaking on this particular topic. I would be happy if any of you have any doubts and wish to contact me for anything in pediatric endocrinology. We would be happy to. answer. Thank you very much.
Thank you very much, Dr. Meghna.
Yes, thank you.
That was really very nice. I hope our students were able to capture all that you said, which is extremely useful clinically. Now, we will see if there are any questions on the chat box. I have one question.
Yes, ma'am.
Like you said about the various applications that you use, do you use any particular application for the bone age?
Yes,
How,
ma'am.
yeah,
So
which
we
one do
have,
you use for
yes.
that?
So we have the Tanner Whitehouse application TW3. Okay, it is a paid application on iStore. Okay, so iOS has the Tanner Whitehouse 3 application, which is costs around 600 rupees or something, which you can download. And the entire atlas comes in, and you can match your X-ray with the bone age and calculate the bone age.
Okay.
So that application is very much available. Okay, Osman Ratib also has an application, okay, for their Atlas, which is free of cost, and you can download it from I think Play Store, Android Play Store.
Yeah.
Madam, one question from our pediatric practice. So, if a child with short stature come to us, how long actually we can wait? Should we wait for consecutive growth chart? I mean, consecutive growth measurement, or should can we just refer straight away to the pediatric endocrinologist?
Ma'am, everything will depend right from the birth weight. Okay. If this
Okay.
is a preterm baby and less than 2.5 kg in birth, you can wait till 4 years of age for them to catch up in height. Okay. And still, if they have not caught up according to their genetic potential, then that's a point to refer to a pediatric endocrinologist. Secondly, ma'am, on a single point, it is difficult to refer, but if you see the growth velocity, at least follow the growth velocity over 6 months to 1 year. If the growth velocity is less than what it is expected to be, then definitely you need to refer. If the plot on the growth chart is very much less than the third percentile also, doctor, then also you need to refer, or maybe you can at least do a brief screening for hypothyroidism and other systemic disorders before referring,
Thank
right?
you, ma'am.
Yeah.
How do you predict adult height based on the growth charts? Suppose a child's parent is asking you, how much can I expect my child to be? Of course, we can speak about the target adult height,
Yes.
but based on the bone age and based on the current growth,
Yes.
how do we kind of give them a prediction?
So adult height prediction is highly specific on bone age, ma'am. Right? It will be difficult to actually give them an exact answer based upon growth charts, except, of course, you can show them the genetic potential and tell them that if everything is normal, they should fall between, somewhere in their target height, right? But exact adult height predictions will depend upon what I use in my clinical practice is the Grulich and Pyle Atlas, okay?
Okay.
And we have the Bailey-Pinau adult height prediction charts based upon the Grulich and Pyle atlases. So that is a useful tool that I'm using currently in my clinical practice, ma'am. Because the Tanner Whitehouse method is based upon the adult height predictions are based upon all the American and the British children that the data that they took, and that really you can't extrapolate for Asian and Indian children. Okay? But at least the best thing and the easiest thing that we can do is use the Bailey-Pinau charts that are available on the Grulich and Pyle atlases. And that is how I kind of predict adult height. That is what I use in my clinical practice because I find that more convenient to use. Yeah.
There are no apps for that, right?
There are
We
no
have to
apps
do.
for adult height prediction, ma'am. Tanner Whitehouse method app just gives us the bone age, but it will not give you the formula to calculate the adult height prediction. Yes, that is there.
And,
Yeah.
and do you use Dr. Anurag Bajpayee's Growth Society charts? No,
No,
not the charts, the app.
no, ma'am.
Okay.
No, not at all, because we are not using SIRS applications or his growth charts because we are all trained maybe in different ways, and we are all like maybe trained in Grulic and Pile and etc. So come back and use that only. So whatever these are standard things that are followed internationally, ma'am. So that is why we're using those references. But I'm sure Dr. Anurag Bajpai would be able to throw more light on his way of bone age calculations.
Okay,
Definitely.
sure.
Yeah.
Ma'am, for the preterm children, is it mandatory that by 4 years they should catch up? Because in our practice, we are not like seeing that preterm
Yes,
children
ma'am.
is little
Yes.
more lagging behind the term children in catching up the both weight and height. So
That's true. Dr. Sujan, what it is,
for
US FDA has clear indications, right? That if the catch up does not happen by the age of 4 years, okay, it becomes an indication for growth hormone therapy straight away. Okay. So definitely if you have children who are not catching up by the age of 4 years, do refer them to us. Okay. So that at least you can figure out whether there is some other endocrinal cause that is contributing to growth failure. Okay. Or is it purely based upon lack of catch up growth? The problem is, Dr. Sujan, that people come to us very late by the age of 11 years, 12 years, 13 years, where the epiphysis starts fusing, the epiphyseal growth plates are fusing. And at that time, to give them an adequate height is very difficult. So the earlier you refer, the more chances there are to get a better height outcome later.
thank you, ma'am.
But then in Indian population, to start growth hormone at the age of 4 years and continue it for many years is a matter of challenge, even financially. Okay. So everything has to be tailored according to the socioeconomic strata that we're dealing with. Abroad, when US FDA made those indications, they made it because everything is insurance based in the States, right? But
Yes,
when you are dealing with our population, I think Dr. Sujan try to optimize the nutrition, give more proteins, okay, and try to use other kind of things rather than growth hormone being started at such a young age. Even though ideally textbooks do mention that yes, they do give a good height, but at
that
least
is a practical difficulty, ma'am, because we try
practical
to convince them, but
difficulty.
it's very
Yes.
difficult.
And even if you convince them, there are very few who can carry on treatment for more than a year. See the prohibitive costs of growth hormone. Okay, unless the government is helping them, right, with this particular indication. Okay, that is also important because I don't know how it is in Kerala, but in the state of Maharashtra, we have some schemes, government schemes, but they are only for hypopituitarism. So where you get growth hormone free by the government. Otherwise, it is difficult to afford growth hormone at such high cost for so many years and for so many years. And Dr. Sujan, growth hormone is quite a new drug, let me tell you. We have data for 25 to 30 years. That too based upon growth hormone deficiency children. Okay, most of it. We do not have much data on SGA children. Okay, so this is an area of ongoing research basically. We do not know what will happen 20 to 30 years hence. Okay, so I always try to optimize nutrition first rather than going into growth hormone therapy. Okay, but definitely if the child is faltering on your growth charts, okay, very much less than the third percentile, at least test the kid for growth hormone deficiency because if the kid is growth hormone deficient, they will catch up magically with growth hormone. Okay. So a lot is not known in pediatric endocrinology. There are lots of gray areas. There are lots of research areas in this field, and I'm sure ma'am agrees with me. Every pediatric endocrinologist has their own way of dealing with various things based upon the country where they are practicing, maybe. Okay, but I think if they are affording, you can refer to a pediatric endo. If they are not affording, optimize the nutrition and see with a high protein diet and all that also helps to increase height and weight, of course. Yeah,
Okay, ma'am. Thank you, ma'am.
yeah, that's the best thing I can probably tell you practically. Yeah.
Yeah, now that you spoke about nutrition, do you routinely supplement calcium to every child in pubertal age group?
No, ma'am, I don't supplement calcium to every child in pubertal age group if the puberty is happening at a normal tempo, right?
Okay.
because bone mineral accrual will happen by the age of 13 or 14 if things are happening normally, ma'am, right? So we just tell them to have any normal milk and normal calcium supplements that are there in the diet. I have never supplemented anything over and above for a normal puberty. Okay, but for those who are on precocious puberty and on injection, GnRH agonists, etc., they obviously are on high calcium supplementation to prevent osteoporosis. That's the only condition where I supplement calcium in pubertal age group if I'm treating them for some pubertal condition. If it's normal, I think I just tell them to optimize diet again. So that is my
Sure.
basic thing. Yeah.
One more question. Do you have any experience treating children with achondroplasia with
Yes,
growth hormone?
very interestingly, I do have. I have 3 or 4 kids who came to us with achondroplasia, and ma'am, I did find very promising results, which I am publishing as well. Okay, they grew almost 8.5 centimeters in 12 months.
Wow, that's
Yeah,
really good.
yeah. But after 1 year, but you have to be very careful when starting growth hormone in achondroplasia. You have to have a very clear MRI. You have to see there's no basilar invagination, foramen magnum, narrowing, etc. Those things need to be absolutely cleared by the radiologist before you venture into anything with growth hormone, because that can create a problem on treatment. So once those things are clear, the MRI radiologists give us a clarity on the foramen magnum, basilar invagination, all those things that can happen in achondroplasics. Only then we go ahead. But ma'am, even in the achondroplasia kid, I did do a growth hormone stimulation test to actually see whether they were also growth hormone deficient, and I did find that in one. So, and that was the kid who actually grew more than 8.5 centimeters,
Okay.
probably. But the body disproportions, they can actually increase with growth hormone. So, those are the things you need to inform the parents as well, that probably the disproportionate growth may actually be more obvious on growth hormone because as they grow taller, okay,
Yes.
so that is why you have to keep a very, very close monthly follow up if you're starting an achondroplasia kid on growth hormone. But it is definitely promising because at least they will reach some respectable height, right? So I guess I will definitely go in for growth hormone for achondroplasia, but after keeping them safe and after a proper MRI, etc. Only then.
Sure.
Yeah.
Yeah, that was a very interesting session.
Yes, ma'am. Thank you
Yes,
very
Dr.
much.
Sujit?
Hello, ma'am.
Okay. So we really enjoyed interacting with you, Doctor.
Thank you. Thank you,
So
madam. Same here.
we are
Thanks
really
for inviting me. And it was a pleasure interacting with all of you as well. And
thank you. Thank you
thank
Thank
so
you,
much
ma'am.
for your time.
you,
Very
ma'am.
useful
Thank
for
you.
our practice. Thank you, ma'am.
Yeah,
Thank you so much.
yeah, we'll be happy to help you out in endocrine, Dr. Sujan, pediatric endocrine, of course.
Okay. Surely we'll trouble you, ma'am.
Yeah, yeah, no worries at all. And please, if the undergraduates require any other topic or they require to know anything on these slides, which is quite informative, you can feel free to share it with them.
Okay, ma'am. Okay.
That's very sweet of you. Thank you so
Thank
much.
you, ma'am.
Thank
Thank you
you
so
so
much.
much. Bye. Yeah.
Okay. Bye
Bye,
bye.
ma'am.
Thank you so much. Bye.
Thank you.